Very good morning to everybody at the outset, and I would like to thank Amit for the opportunity. I have been lucky thus far that everybody went into the concept of when to treat and what to treat. My role has been you have been treating, so how long do we treat? When do we need to modify the treatment? And what could be a guideline for how and when we can actually think about stopping the medication? Before I get into that, there are some very interesting findings that despite the relatively limited evidence for the efficacy of immunosuppressive treatments in uveitis, it is generally accepted that a delay in referral to a uveitis patient specialist, a delay in commencement of the immunosuppression, and inadequate immunosuppressions have been the main reasons for a poorer visual prognosis of all the ocular inflammatory diseases. As Andy Rees actually mentioned, that early on you regret too little, and late on you regret too much. And if we understand this whole process, I think central to the management is the patient's understanding of the disease and educating the patient about the potential life-threatening situations honestly is important, and reinforcing the importance of blood and lab evaluations and the internist is very appropriate. Now, if you look at the basic immunology, I think this is very essential before we start these, because mediators are part of the intracellular and the intercellular signaling that allows the cells to respond based on the past and the present antigen exposures. This actually leads to the abnormal regulation, which can manifest as either an autoimmunity and an excessive inflammatory response, which again has two components, either the innate or the adaptive immune system through its own respective cell mediators. Acute management, we are all very consensual about the steroids as the options, and the long-term management involves the minimizing the excessive healing response. That's the entire criteria in the management. We are all aware of this algorithm. We have a couple of steps, and the most important that I would actually like to talk about is treat for long term, especially combinations or only immunosuppression or modulatory therapies individually. Now, an ideal scenario that we would look at is a quiet anterior segment, a dry macula, a steroid-free, no remission, no recurrence free patient, so that we can avoid the complications of the steroid. But in the clinical settings, it's very difficult. So we look at certain therapeutic responses. And in terms of our monitoring, every visit needs to follow a subjective and an objective visual acuity assessments. Assessment of the inflammations in the anterior segment, especially in respect to the cells. Assessment for inflammation of the vitreous cells, especially whether they are anterior, intermediate, or posterior to in the vitreous cavity. Activity in the area of the choroiditis patch in case you are following. Activity of the vasculitis in case the vasculitis has been the reason for the immunosuppression. And optic disc and macular edema are major criteria because they are vision-threatening situations. So the parameters at each examination, I'm sure all of us do this regularly. Now the right side indicates the diagnostics which have to be used judiciously, whether you want to use an FA or whether you want to do an OCT or whether you want to do an autofluorescence. I think a judicious mixture of these will actually give you an answer. So in the anterior uveitis, most commonly we have the cells as the guide for us to monitor. So if there are cells, we need to continue the treatment. But then this issue here is that if you are also adding steroids, which are most commonly used for anterior uveitis, then I think you need to worry about the structural damages for the cataract. In fact, in children where the anterior uveitis, especially the JIA and the B27 positive uveitis seen there in chronic idiopathic uveitis in children, it is much better seen that the JIAs are more common in women, but even it happens in boys. And there, if the steroids are given for a long term, you have a problem of growth retardation, which is never, catches up when the guys grow up. Now, then assessment of the intermediate uveitis, apart from the visual acuity, you look at the vitreous haze, especially in the anterior 1/3, and you do a monitoring of the macular edema, the vasculitis component, and the disc edema. Posterior uveitis is almost similar like the intermediate, and pan uveitis too mentions the same kind of a protocol. This is a very interesting thing. Steroids are anti-inflammatory and immunosuppressants are modulatory. Now, patients treated with corticosteroids will always rebound unless the disease has run its course. It's reported that in acute anterior uveitis, the disease usually runs for about 8 weeks. In weak age, it can go as high as about 18 months. And patients treated with immunosuppressants may be able to alter the underlying mechanisms of the disease. Like serpiginous, it can go on up to about 5 years. But what's the end point that we look at? So you are either waiting it out so that the disease goes off on its own natural course, or you're suppressing it so thoroughly that the feedback to perpetuate the disease is broken. So either of these things can actually give you a finale for your immunosuppressive treatments. Now, if you look at the commonly used methotrexate, we ideally start it along with the steroid, and so the immunosuppression and the steroid, which started together, by 8 weeks' time, we see the response. And if at 8 weeks the response is adequate, we follow the same dosage pattern till it burns out. In case the response is inadequate, we then increase the dosage per week. And every time we increase, we wait for 6 weeks to see the response. Now, if we look at the pattern, what happens is, if you have an inadequate response, you can increase the dosage. But in case the dosage gives you an adequate effect, you are fine, you can continue till the disease burns out. But in case there is a positive but an incomplete effect, you again increase the dosage to the maximum permissible for you to get an adequate effect, and then continue the monitoring till the disease is either on its own you wait it, or it doesn't recur further. Now, most of us have actually mentioned about these guidelines. I thought I'll just go through this sudden summary, because this is based on the guidelines that have been provided by the American Journal of Ophthalmology's publication in 2000, and it clearly indicates that immunosuppression is indicated as a sparing agent for steroids for patients with uveitis if they are unable to be tapered to less than 10 milligram daily by 3 months. So within these guidelines, these are very strict guidelines, and they actually said that immunosuppressions are indicated for certain types of uveitis before corticosteroid dependence is confirmed. And these are the ones that we talk about. And if you look at some other things are also there which are not mentioned in the guidelines, but we do follow them, is children requiring more than 4 times of daily topical steroids to control the iritis. I think these primarily because you don't want to get into the steroid-induced complications. And children are very, very intolerable to the side effects. And the other thing is cataract especially should be avoided at every cost, because it creates structural damages on a long-term basis. The other indications are been mentioned. Now the question here was there a compliance to these guidelines? I think Nguyen in his survey in ophthalmology in 2011 did recruit some professional recruiters to rope in about 60 ophthalmologists and 3 rheumatologists, And the criteria was to see in case each of these participants were managing at least 10 patients with uveitis. Now, cutting the long story, actually 62% received oral corticosteroids with starting a mean dose of about 45 milligram, tapering it to a mean dose of about 30 milligram, and on a mean time of treatment remaining around 25 months. And if you see the use of the immunosuppressives, it has been seen, they have done the study based on the anterior, intermediate, posterior, and the pan-uveitis component. The purple indicates where they have given immunosuppressants, and the topical one is in the red, which were more mainly injectables also included. Now, what was important that came out of this conclusion was that most of them did not follow the guidelines. The corticosteroids were too much and too long. The steroid injections used to spare oral corticosteroids rather than immunosuppressants. This was something very interesting. And then if you get into the retrospective multicenter site study of the cohorts, this is again, they looked at the use of these immunosuppressants in different situations and how much did it control the inflammation, and did these patients comply with the thing, or how many did they drop out. And mycophenolate was the most acceptable of all the lot. There was only a 12% discontinuation at the end of 12 months, but with a very high control of inflammation up to about 72%. Now, what does all these things tell us? I think we have guidelines there, but most important is you are the main person, you are it. And what you need to do is you first need to be very, very thorough with the guidelines. You need to look up the doses, never get into a confusion. So look up the toxicities, you follow the monitoring guidelines, collaborate with, but don't just consult with the rheumatologist. And the only other caution I would really look at is don't overdo the vitrectomy surgery or injections just because you know how to do them. Thank you.